This podcast is a production of OPENPediatrics, a free online resource for health professionals' education. Visit openpediatrics.org for more.
Welcome. This is World Shared Practice Forum. My name's Robert Tasker. I'm the Director of Neurocritical Care, and today I have Dr. Pat Kochanek with me, who is the R.K. Grenvik Professor of Critical Care Medicine at the University of Pittsburgh. He's also the Director of research at the Safar Institute, and most importantly, you'll all know him as the Editor-in-Chief of Pediatric Critical Care Medicine. And in 2017, he was the Thomson Reuters Science Watch most prolific writer with most citations in the field of traumatic brain injury research. Today, Pat is here to talk to us about the new third edition update for the Brain Trauma Foundation guidelines in traumatic brain injury management in children. So, Pat, I'd just like to ask you, how did all of this come about? It's a huge organizational achievement, but how did it start and how did you get here?
It's a great question, and thanks for the kind introduction. The guidelines have been a process that, as you know now with the third edition, are one that brings together a really multidisciplinary group of people, not only intensivists and neurosurgeons, emergency medicine, anesthesia, child neurology, etc., but also evidence-based medicine experts and obviously all the people required to do all the publishing. And it's a process that was many people may not know that a couple decades ago this was tried and failed initially by other groups, and in large part, Nancy Carney and the Oregon Health Sciences Group with the Brain Trauma Foundation kind of assembled a group of people with the first edition of the guidelines that were able to finally take it to the finish line. And now the third edition is really come together, and although it's a huge undertaking, it's so much easier than it was in the beginning. And beyond the actual people whose names you see on the masthead of the documents, there are other people. Hector Wong, for instance, served as the guest editor to, in essence, address any potential conflicts, and he brought on reviewers to review, and so there's a huge cast. But as I mentioned, I think it was a lot easier this time than it was, particularly the first time.
Thank you. So why have we got 3 documents this time? Talk us through that.
I think it's really great. First of all, that's my initial reaction, the fact that we have 3 documents. In fact, if you look back at the greatest critique of the last edition of the guidelines was that there wasn't a bedside handbook, an algorithm type of document. And I think that if you look back at the guidelines, we have 3 documents now. You can see that we have the full guidelines. And the full guidelines, of course, are essentially the Bible, but they have everything in them. And but we then also this time and have published now, rather than as a supplement, in the regular pages of Pediatric Critical Care Medicine, and duly published in the regular pages of the journal Neurosurgery, we have an executive summary. And that executive summary is a thumbnail of the essence of what has changed, that there are 22 recommendations and there are 9 new recommendations. And so that is really a distilled, easy-to-read version. And if nothing else, I suggest you read the tables of that document. And then this time, we did something that we did in a very Spartan way in the first version of the guidelines, and that is tried to put together a bedside caregiver's document, an algorithm that isn't just evidence-based, that is consensus and evidence-based. And if you were to go back to the last guidelines, the number one, if you want to call it, complaint of people was, where's the algorithm? Where is my bedside document that I can look at? Are there a couple of charts that can help guide me through? You could argue, why wasn't there one in the last document? And that's an interesting point. And the reason there wasn't one is that in that era, the Brain Trauma Foundation was in, if you want to call it, kind of a purist era. They wanted to minimize consensus. They wanted evidence. And so an algorithm was, in essence, not sought out. And I think hearing all of the feedback that we really need something like this, because the evidence is better, but it's still not solid enough. And so this algorithm article, I think, is a fantastic addition. We'll talk a little bit more about it later, but it's a really special addition. So that's why there are 3 documents. Really, from a logistic standpoint, if you read the executive summary and use the algorithm and have the full document as kind of your backup if you need to really go into the details, I think that's the best way to navigate the 3.
Can I just interrupt?
Yes, yes.
So all of the previous recommendations and levels of evidence were relating to the outcome of death or mortality. Here now, we've introduced a different outcome level, which is ICP control. Perhaps you could just talk us through that.
That's a great point. And it's a very interesting point in that really there's been no definitive positive study that has ever shown that an intervention improves outcome in severe TBI in children. And you'll see in a minute, we've certainly had one that has at least at a level 3 evidence, if I remember correctly, supporting against, and I guess we've had a couple of those. Outcome has been such a difficult parameter, whether it's mortality or whether it's Glasgow outcome scale, to get a therapy to favorably affect that the next best surrogate that we have, obviously, is intracranial pressure. And so we have 2 different types of targets for our recommendations. One is it useful for outcome, for improving overall outcome? Can we really make a recommendation in that? And the other is, can we make a recommendation to control ICP? As you know, the evidence to definitively say that controlling ICP improves outcome is also just not solid enough. And so thus the need for a dichotomy between those 2.
Perfect. Thank you. So perhaps you could take us through the evidence tables that are summarized in the executive summary, just to highlight various aspects here.
Yeah, as I mentioned, there are 22 recommendations, and there are also some other notes within the tables, and they're very useful. And there are 9 new recommendations. And so if you look through the executive summary tables, you see that, for instance, the recommendations for monitoring, probably the hottest topic on the planet is ICP monitoring. And based on the available evidence, there is a recommendation for the suggestion for ICP monitoring. It's interesting that there is that recommendation given the fact that almost everything that you do is based on using ICP monitoring. And we'll talk a little bit later, I'm sure, about if you don't use ICP monitoring, you're still stuck with, in essence, ICP-based care without the number. So there is at least a level 3 recommendation for that. There's also, once again, a recommendation for advanced neuromonitoring for PbO2, partial pressure of brain oxygen, and with a Lycox monitor, and it's a parenchymal monitor for those who aren't familiar with it. And if you do use one, that you target a level of above 10 millimeters of mercury. And that's a threshold. We'll talk a little bit about thresholds in general later. It wasn't felt that there was enough evidence to support a recommendation for use of the monitor. It's used more commonly in research institutions, et cetera. But if you do use it, that was the threshold that was recommended. And then there are two recommendations on neuroimaging. One, that a normal CT scan does not rule out increased intracranial pressure. And I think that's an important recommendation. And also that routine repeat use of a CT scan is not recommended unless, of course, there's some clinical deterioration. And
all of these are level 3 recommendations.
All of these are level 3, as you can see. Yes, and I'll try to point out the 3 level 2s with a little bit more clarity.
Thank you.
And then with the thresholds, there are again level 3 recommendations for an intracranial pressure threshold of 20 to keep it less than 20. And that is interesting because, the latest adult guidelines had a 22 recommendation. And it's interesting also that with this recommendation, I think like cerebral perfusion pressure, there may be an age-dependent value. It might be that in an infant, 20 is a little high, but we just don't have the evidence to say more. And the same as with cerebral perfusion pressure, we had a recommendation once again for a minimum of 40. But we also have a recommendation that 40 to 50 may be a more practical recommendation given that we don't want to breach that threshold of 40. And we also mentioned there may be age-specific thresholds, specifically for CPP, given the well-recognized age dependence of blood pressure and the importance of blood pressure in the CPP calculation. But once again, we can't make specific recommendations. I think one of the papers from your center back in Cambridge when you were there was one of the best that came as close to giving us a shot at doing that. And maybe future studies will be able to pin that down a little better. So for hypertonic saline now, we do have a level 2 recommendation for bolus administration of 3% and with specific doses. And I think that's a nice advance in this guideline. I think the paper by Steve Shine I think really helped contribute to this because it was the first time that an actual comparison between therapies, first-tier types of therapies, whether it was hypertonic saline or fentanyl, et cetera, provided evidence that the hypertonic saline not only improved ICP, but it also was the only therapy that improved CPP. And that was kind of an exciting finding from that. We also continue to have level 3 recommendations for hypertonic saline as a continuous infusion, and that was in the prior guidelines. But now another new 23.4% hypertonic saline recommendation based on studies from down under, I guess you would say. Really exciting to see. I'm sure, and maybe the audience isn't as aware, but 23% is used much more commonly in the adult world. Interestingly, that I think the pediatric field, largely related to the work out of San Diego, brought hypertonic saline back into the armamentarium with 3%, and then the adult world brought the 23% in. And now we have a 23% paper in pediatrics. So having that in your armamentarium.
Just to make clear, we couldn't find any studies in regard to mannitol.
It's a really great point, and despite the history of mannitol use, I'm really hopeful that ADAPT will now be able, the ADAPT trial led by Mike Bell, which just closed 1,000 patients, comparative effectiveness trial, funded by NINDS, and I'm really hopeful that is going to give us some insight into the effect of mannitol. Part of the reason we don't have evidence for mannitol is that some of the really early studies supporting its use were, in essence, accepted. Yeah. And people didn't feel the need to replicate them, but the studies in that era just don't hold up to the rigor of today's type of reports. And so it's a bit of a conundrum, sure. And it's kind of a bummer, I guess you would say. But it doesn't mean that we don't recommend against mannitol as an alternative to hypertonic saline. We just don't have the evidence in the articles to support its use. The other thing with regard to the hyperosmolar therapy is that, once again, we have some safety recommendations showing that sustained increases at high levels, and whether you pick 160 or 170, you start to see complications. And whether it's evidence of an endotheliopathy with thrombocytopenia and pulmonary complications, or whether you have thrombotic complications, it starts to come in. And so you get a trade-off for use at those higher levels. Then also, we had some other new recommendations this time. Again, very exciting. A category that I think pediatrics has also led the way in initially. We were kind of the first people to put a chapter in on sedation. We didn't have much to say, but I think it really stimulated some studies. And the study out of WashU showing that midazolam and fentanyl combined in particular was associated with not an improvement in ICP when used as a bolus, but actually some deleterious effects. It was somewhat of a complicated study, but there were clearly some signals of a deleterious effect, allowing us to have a level 3 recommendation against routine bolusing of those agents. I think it's really important, though, to recognize that in that recommendation that we are assuring that the patient, the kid, is already adequately sedated.
Yeah.
So this is not to tie the hands of the caregiver to not sedate or provide appropriate analgesia to kids with severe TBI, but rather, if you're already doing that, just coming in with additional boluses don't seem to produce important improvements in ICP. Although if you were to compare the study from WashU, Jose Pineda's group, they saw really predominantly negative effects. In Steve Shine's study, we saw some benefit on ICP, but no benefit on CPP. I think taken together, it really argued more for give boluses of hypertonic saline or other therapies if you are adequately sedating. And of course, another very important difference between the adult guidelines and the pediatric guidelines. In the adult world, propofol is in a number of studies been shown to be a very good way to provide sedation in neurocritical care of adults. But obviously, with a black box warning, it's just not on the table in pediatrics. And although we don't have a study in TBI saying we can't use it, you could argue there's something at a higher level preventing the use of it as a continuous sedation approach in pediatric TBI. I also wanted to mention that we don't have a specific recommendation on neuromuscular blockade, but we do say that its use is up to the treating physician. And we deal with that a little bit more in the algorithm.
Yeah, thank you.
We also have a number of other level 3 treatment recommendations: cerebrospinal fluid drainage if you're using a ventricular catheter, seizure prophylaxis, level 3 also. Although we didn't have evidence to say levetiracetam or phenytoin or fosphenytoin were better, either was better. And then we also had a level 3 recommendation against prophylactic hyperventilation. However, if you have refractory intracranial hypertension now, kind of as a second tier, hyperventilation can be used, and there is a level 3 recommendation for it. And once again, I think that becomes a little clearer on the algorithm. It's kind of like what you use up front versus, hey, we're not winning, now what are the choices I have? Yeah. I guess would be the way I would put it. I think one of the greatest improvements in not necessarily as much related to the new data as much as related to the interpretation of it has come with the temperature control. And we now have a level 2 recommendation. And now this, as you are talking about, this is with overall outcome, as was the early hyperventilation, not for ICP control, but for overall outcome, a recommendation against prophylactic hypothermia. So if a patient comes in, you just immediately cool them in kind of a neuroprotective fashion. And despite how wonderful that sounds, and despite many animal studies suggesting that there was some potential for that, it's just never panned out. Although we still don't have, in essence, perfect studies on that, there are some signals that during rewarming you might run into some difficulties. And I always say hypothermia is not a pill. It's complicated. And so in those studies, if anything, there were some trends in some of them for deleterious effects. And so we have a level 2 recommendation against doing that. However, for ICP control, once again, if your first-line therapies are failing, moderate hypothermia to attenuate intracranial hypertension is on the table.
So it's like a differentiation between what you would do first tier and then what you would do second tier.
Exactly. It's a preventative strike with mild cooling is not recommended. In fact, we recommend against it. Whereas if the conventional first-line therapies are failing, hey, this is something that there is evidence to say that it can control ICP. And that's a very different situation than upfront application. And similarly, for refractory intracranial hypertension, we have level 3 recommendations once again for barbiturates and for decompressive craniectomy. And those are basically the same. There was a little bit more evidence supporting them, but still all at level 3.
I mean, perhaps it's also worth just mentioning that we did have pediatric neurosurgeons review all of the evidence on the decompressive craniectomy literature to go through that in really quite some detail as well.
Oh, yes. That was something that I think in all 3 guidelines we have been very, very mindful to be inclusive on the team. And I think that everyone felt comfortable with every recommendation. I think there really was a consensus on the evidence portion of it. I think there was an excellent consensus even on the algorithm. But there was strong agreement, and even recognizing that some centers use decompressive craniectomy in a more prophylactic way. But I think the evidence that we can state in the guidelines are the use of it for a refractory intracranial hypertension or a neurologic deterioration, etc. It could be that you would use it up front if you had a terrible injury with a large parenchymal lesion, etc. But it is in that context. And then the final 2 areas in the treatment, one is in nutrition, and there is a level 2 recommendation that once again is in the guidelines. It's a really excellent study, but it's a study on a very specific immune-modulating diet. And the study was well conducted and thus enough to give it level 2 recommendation. But beyond that, for not using that diet, it doesn't help us very much because it was so specific. It's an excellent study, but it's difficult to generalize beyond it. In contrast, we now have another new recommendation to start nutrition within 72 hours. That approach is even stronger evidence subsequent to the guidelines. Again, and that's for improving overall outcome. It's a level 3 recommendation, but it did not differentiate whether you exactly what kind of rate of enteral nutrition or exactly what the recipe was. But I think it's still a first step forward on that. And then finally, interestingly, the recommendation on corticosteroid use moved from a level 2 against to a level 3 against. And people may not realize this, that, well, we're humans putting together these guidelines, and the backdrop upon which they are crafted changes with time. This is, to me, is a really interesting example that earlier on when the CRASH trial came out, it was a study of steroids in adults with thousands of patients, negative, deleterious. It influenced the field like a hammer. And I think that that study probably was given too much weight by us in the past. And as we've looked more rigorously and said to ourselves, but where's the pediatric evidence? We have said, and maybe part of it is, well, we've gotten some better pediatric evidence for other pieces of this. So that study, even though it's I think a level 1 in the adult guidelines, it's not a pediatric study. And so we can't just simply extrapolate. And the pediatric evidence is really level 3 against corticosteroids. And the other thing I think that we are trying to be very mindful of is that we don't want to tie the hands of our caregivers to not be able to use steroids in the setting of adrenal suppression. And whether it's etomidate or whether it's prior steroid use or other problems,
HPA axis.
Sure,
injury.
HPA axis injury, absolutely. And so I think in that setting, we moved that from a level 2 to a level 3. That's one of the more interesting nuances, I think. If you weren't really looking carefully at the guidelines, you wouldn't have thought that changed. But it's an interesting thing.
So that's a great summary, Pat. And you sort of alluded to it when you mentioned that there have been other studies coming out since this was all written. And the question is, do we have to wait another 5 or 6 years before the next set of guidelines, or is there going to be a completely different strategy with dealing with new evidence as it comes out?
It's a great idea. A living guidelines is something that has been discussed. I think that there is interest from the Brain Trauma Foundation of doing that. It's not easy, though. It takes a lot of work. And I think that it probably takes a certain level of financial support, too. And so exactly whether that will come together, I don't know. I really don't. I think it's a great idea. I think the other question is, a living guideline kind of is so logical now. I mean, heck, everyone just goes to their phone for what happened last night, I think that is certainly where it's going to go. I think it's interesting that we're almost in a scenario where the mechanics to make that happen in the transition need to be worked out. And I hope it does happen, but I do think that it's not a trivial undertaking to do. That's how I would describe it. I would think if we could update at least every year or 2 years, that would be even a step that probably is going to be necessary, because otherwise these become outdated pretty quickly.
Thank you, Pat. That was really clear. And now it comes to the bedside document or the algorithm. Perhaps you could just sort of talk us through the concept and the figures that appear there.
Yeah, as I mentioned a little earlier, with the first guidelines, there was an algorithm. We really, at that point in time, we felt it was really important. That initial algorithm in that first document, though, was really a synthesis of the evidence into an algorithm with a little bit of consensus. It was still a very largely evidence-driven document. As I mentioned, the Brain Trauma Foundation, with the second edition, really pushed for we need pure evidence, and kind of almost a religious kind of approach. And this time around, I think it just became so clear from the feedback that we received that people want more than that. And so we put together, and I'm really pleased to say the two of us together are the co-lead authors of this. And I think it's a fantastic thing. I think it's one of the best things I've ever been part of in my career, that tried to really build a much stronger consensus layered upon the evidence, and address some issues that are really neglected. And it was really fun, even discussing this at the Guidelines Committee. We had great people, Mark Wainwright and Mike Bell and
David Adelson.
Dave Adelson and Monica
Nate.
Alalala, Nate Selden, and everyone was weighing in on this. And things like, TBI is this multifaceted disease where you have ICP, CPP, brain tissue O2, all these different readouts simultaneously, and each of them is their own linear pathway, but they influence each other, and there's never any discussion of those in kind of a sterile guidelines document. Or things like the tempo. I always chuckle because when we were talking, Mike Bell had a great comment. He said, you have a guidelines and you have a level 1 pathway, and you say, well, in one patient, they blow through this in 15 minutes. In another patient, it's like they behave and they follow it, and their ICP raises over several days, and you can just nicely implement the therapies. But you're stuck with the same sterile guidelines. Things like weaning. You can read through all the guidelines, and no one ever says, well, is there anything about weaning? How do you take the therapies off? We all do it in our own way, and we all generally take the most toxic and the last thing on as the first thing off, etc. But no one ever discusses it. You just don't find it in a document. And another point in the algorithm that I think is really important, and this became we discussed this, and I think we were really excited when we started discussing this, and that, thresholds that are generated in guidelines documents are the minimum threshold. And the classic, obviously, is a CPP of 40, and we say, man, that's low. And if you're targeting 40, you're going to be in the 30s some time period. And we're going, wow. But you're stuck with that. And so the algorithm article discusses, I think, really nicely that these thresholds are minimum targets. And whether it's a hemoglobin of 7 or an ICP of 20 or a CPP of 40 or a brain tissue O2 of 10, heck, you can find articles that say we should use 25 or 30 as the target. But the strongest evidence, the most cautious, of course, is 10. And you might argue, well, why not just raise those empirically? But more therapy might also get you into trouble. And so, running something too rich, look at with fluid overload now. It used to be, I used to say, pour it like you don't own it. But now we are all saying, hey, there is a price to pay for these things that we do in the ICU. And so the concept of a minimum threshold is one that we discuss in the algorithm.
We would like now to turn to the audience to ask a question. When you respond, please leave your city and country. What did you find most helpful about the 3 new guidelines documents?
I think we're really pleased that it's nice visually to look at. You see the linear pathways. You see the potential interaction. The first tier algorithm, which is, I think, a really nice graphical display, builds on the baseline care. And these kind of things, if you look back at the prior guidelines, in the introductory article were kind of a brief discussion, but they weren't really laid out for the bedside caregiver. And I think this time, for the first time, we've really laid them out and said, here's a straw man to utilize, and going back to Mike Bell's analogy, you might have a patient that blows through this in a few hours. And then you might have another patient that never progresses to second-tier therapy, that some approach to this, some utilization of this allows you to do all of your management. I think one of the other things about this that I always personally felt we fell short in the prior guidelines is herniation is so devastating. It's just so important, and yet there are no studies on it. Even in the adult side, there are only a few studies on herniation. It's really interesting if you look at those adult studies.
And you mean what you would do in an emergency?
That's right. And not only what you would do, but what are the consequences?
Yes.
And it's not like, well, we're going to randomize to A or B in herniation. That's a little tricky. And not to say that it couldn't be done to try to improve what our best approach is on that. But I think one of the things, if you look at some of I think there's about 3 adult studies on herniation. The interesting thing is that there's a pretty decent number of patients that herniation can be reversed. Yeah. We think of it as is so devastating, and rightfully so, but it's not always. And the early signs and symptoms in some patients can be reversed, and it may be 40 or 50%. And so that's really important. All the more reason to have a recipe. And so we have what I call the herniation pathway, and it has a nice backdrop on, well, what are the signs and symptoms, because it varies from patient to patient, obviously, and then how do you manage it? And that is the setting that hyperventilation titrating to pupillary, reversal of pupillary dilation is indicated, and on an FiO2 of 1, and then bolus mannitol or hypertonic saline. It's interesting in the adult studies, it's usually 23.4% saline, but I think in pediatrics, the guidelines committee felt that in this setting, more people are comfortable with mannitol, and what we didn't want to do was to try to introduce something new in that crisis setting that people are trying to find something that they're not prepared for. Maybe that will ultimately evolve, but that wasn't the goal of this. And then, of course, if you have an EVD in place, to open it and make sure you're maximally draining CSF. And then get to
imaging, surgery.
Of course. And so having that kind of crystallized on there, if it saved 1 or 2 kids, it was a great addition to these. And then, as I mentioned, within this, we have a nice discussion about an ICP pathway and how do you progress down it. And the CPP pathway, what do you do to add to this? And then the brain tissue O2 pathway. And one of the things that's always brought up, well, how does one influence another? And the classic example, I think, that is really a nice one is that if you were in a unit and you're monitoring all 3 of these, and you have a situation where the ICP is under control and the CPP is under control and your ICP, say, is 16, and you're on osmolar therapy and it's taken barbiturates to get to that. But now you have a patient whose brain tissue O2 levels are low, say they're 7 or 8. And you're saying, well, our ICP is under control, but our brain tissue O2 is inadequate. Should we just be satisfied with that? A classic example is to say, well, let's let the PCO2 rise a little bit, or let's raise our blood pressure a little bit.
Hemoglobin.
Transfuse, yes. Do an intervention that will maybe improve brain tissue O2. So now all your targets are adequately addressed. Even recognizing we don't know exactly what the best value is.
But the range of targets for each of these and references to the individual protocols that people use are all in the algorithm paper as well.
Yes, absolutely. And then, of course, once you get beyond this, you, of course, have refractory intracranial hypertension. and another tier. And you could argue, well, is it artificial to really consider this a tier, et cetera? I think maybe in the past we might have thought to some extent that's the case, but now I think you can see from the new guidelines, by having level 2 evidence for hyperosmolar therapy, kind of opened the door to really more definitively say, yes, that's level 2 evidence, and that's a therapy that in general, until you get to high levels of sodium, is probably reasonably safe. And now you get to therapies that are much more risky. And so if you're not controlling ICP with that first tier of therapies, you have choices. And as I mentioned, barbiturates, moderate hypothermia, hyperventilation, and pushing osms.
I like the way this is presented now because it's not linear. We don't know what order to do these things. You know, would you do barbiturates and then hypothermia, or hypothermia then barbiturates, or the hyperventilation? Have you got a comment about that?
Yeah, that's a really great point. We not only don't know what order, that this should be first and this should be second, but we also don't know because commonly you need more than one of these. We all have tons of patients where, hey, we've had to go to barbiturates and push a hyperosmolar therapy to 165 or whatever, and or push ventilation, or hey, we have to cool. There are. So what combination? Not only what order, but is there a combination? And I think two things come to mind with me, and that is that combinations are common, and we don't know which one's better, but also it may be that either individual use or combination use, the efficacy depends on the center. Because I think that these kind of advanced therapies they take skill. They really do. You start barbiturates, you better be ready to support hemodynamics. And I remember Brad Peterson from San Diego saying, I would never allow the blood pressure to be low if I started a barbiturate infusion. With that kind of mindset that you don't start it and wait for trouble, you are all over it. You've got the pressor essentially teed up to the patient at the time you start it. And there may be some centers that are great at decompression, and they want to go to decompression at that point. Obviously, the evidence, even on the adult side, pretty equivocal on that also. But so I do think this may vary depending on the center. And I think the other thing is that this whole guidelines, the backdrop of it, is as if we are dealing with one disease. And we know now that it's very likely that the phenotypes of TBI are going to be important. And it may be that, particularly for something like second-tier therapies, that one type of second-tier therapy is way more effective. Say, if you have someone with diffuse axonal injury and diffuse swelling, that may be very different than someone who had a big subdural and has a focal lesion or a big contusion. And so ultimately, this will evolve to something much more elegant.
We would like to turn again to our audience to ask a question. When you respond, please leave your city and country location. What do you think might be changed to improve the value of future guidelines to caregivers? And the other component of this, if we're going to go to these advanced therapies in the second tier, we've also got a section on advanced neuromonitoring. And there wasn't a great deal of evidence in the main document to support these, like EEG, transcranial Doppler, so-called PRX, etc. So have you got a comment about that component?
If you look carefully at the algorithm document, we do make some comments, even in the first tier, to say that, for instance, if you use neuromuscular blockade, we strongly suggest using continuous EEG. And obviously, once you start to get into these more second-tier therapies, advanced monitoring, I think, can be very helpful. As you say, we don't really have great evidence. I'm one of the people that believes that it's nice to have advanced monitoring as much as you can from the word go, recognizing that you don't overreact to any one monitor. I really think that, as with therapies, I'm a believer in a little of a lot of therapies rather than a lot of one therapy. That's where I've seen people get into trouble, is almost being a zealot about one approach and pushing it really. And I think that we see in all of these therapies that their toxicities are dose dependent. And so if you can use a little of a lot of therapies, almost like an artist, you can, and with many advanced monitors, I think that that's one of the ways that you can optimize outcome. I don't think we're there yet in a guideline or an algorithm, and I'm just saying that kind of off the cuff.
That's a wish for the future.
But I do think there is something to that.
There's perhaps one area that I just want to pull you back on and sort of garner your thoughts on, and that's the question of what if we haven't got invasive ICP monitoring? What do we do?
I think that is really a burning hot question right now that was really set into motion by Randy Chestnut's Best Trip study published in the New England Journal a few years back, and then more recently Tellen Bennett's JAMA Pediatrics paper, and questioning whether this is really the key target that we should be aiming for. And I think it's so interesting because we're really excited that we actually do have a section in the algorithm article about this question. And the real gap, though, is that if you don't use ICP monitoring, that there is no pediatric, not only data, there isn't even a consensus or single center description of how you should manage it. And in Tellen's paper, which wasn't a study of how to do it, it was just the way some people are managing what's happening, what are the consequences, can we use statistics to try to sort this out? And in that paper that questioned it, there was no protocol. Yeah. There were some percentages of what percentage of people use barbiturates and what percentage of people. So, we don't really even have a document in pediatrics. But we do have Randy Chestnut in the supplement to that article in the New England Journal, if you go in there. And they, of course, titrated.
And they recruited over 12-year-olds, I think, in that study.
Yes, that's right. And they titrated to clinical exam and imaging. And I think that if you look at the results of that paper, there are just some truly fascinating results. One is that in many cases, the amount of therapy that was used was greater than if you used ICP monitoring. And it kind of makes sense that if you just have to guess at what kind of brain swelling there is, that you're going to need to overshoot. Because if you run it too thin, then you could get into trouble. And so obviously using those metrics, exactly how often you were to scan, et cetera, is totally unclear. But if you were to use those kind of metrics, you would use the therapies that we have developed based on ICP monitoring, and then just have to empirically implement them and write your own protocol as to how you want to do it, or try to use the Randy Chestnut protocol in a pediatric analog of it. But you would have no evidence other than the evidence based on ICP. So you can't get around the ICP influence on it. I do think there's one other take-home point, though, from those studies, and that is I really believe that it may get back to the phenotyping, that we have underutilized imaging to help us guide our treatment. Not so much we don't get enough imaging, but we in general have gotten imaging to say, oh, they need to go to surgery, rather than, wow, there's still a lot of swelling there. This brain looks tight. It's almost like getting a compliance readout instead of just an ICP readout and saying, hey, we're going to need therapy for a longer period of time. And I don't think we haven't in any way skimmed the surface even of how we might use imaging. And if we could get bedside MR, for instance, and perfusion MR and things like that, I think it could really help influence our care. So I don't have an answer for the no ICP other than if that is the approach, you need to craft a protocol based on the Chestnut study, and we really need the results of those kind of things, if that is what you're doing, to be published. And remarkably, it seems like the number of centers that don't use ICP monitoring or use them in selected patients is pretty substantial. And the other thing that I would say about that is the ADAPT trial isn't going to provide us any information about that, because obviously in that trial, ICP monitoring was an entry criteria. So that still will be a gap, even if ADAPT gives us some clues as to how to better manage. I'm hoping that based on ADAPT and the other studies that we actually become better at utilizing and treating ICP, and that it will lead to better outcomes rather than trying to take a step back and fly blind, I guess would be the way I would put it.
Thank you very much, Pat. It's been a real pleasure to speak with you and talk about the guidelines document. It's a huge and massive achievement. Thank you.
Thank you, and it's in the March issue of PCCM.
This has been a production of Open Pediatrics. Check out the description box to view the resources and journal articles referenced in this podcast. To hear more podcasts like this one, log on to openpediatrics.org.